But that's really funny. All right, so for the people, the live people, like I said, you want to have one of those handouts. One side is pharmacist questions and the other is technician questions, but you guys can all answer all of the questions, whether you're a pharmacist or technician. And we're going to use the little cards that say A, B, C, or D for you to answer your questions. And I guess I will go ahead and get started because it's just about 2:30. Thank you guys so much for coming today. I really appreciate you all taking the time out of your workday to come listen to this presentation. I'm excited to be talking to you today about pharmacologic therapy for our chronic NICU patients, a little glimpse into what it's like to be growing up in the NICU. And I have nothing to disclose related to this presentation. I'm not going to read through the objectives, but there are 4 objectives for pharmacists and 4 for technicians, and they're all printed out on your sheet in front of you. I don't need that sheet back. It's just for your reference to follow along through the presentation. As many of you know, we recently celebrated a first birthday party in our NICU. This certainly wasn't the first, and it won't be the last. And as you can imagine, these kids have hugely different needs developmentally and pharmacologically compared to our tiny premature neonates that we normally admit. And this is one of the reasons I really love working in the NICU, because you get to see them go from being a tiny newborn 24-weeker to really truly growing up in the NICU and going through all those developmental stages, sometimes even until they're celebrating their first birthday. Bronchopulmonary dysplasia is really the biggest, most significant disease state that we see in these older chronic NICU babies. It's also synonymous with chronic lung disease of prematurity. And it really all stems down to the fact that they're born with an immature lung. The saccular phase of lung development happens during the 3rd trimester. So when a baby is born before they've completed the 3rd trimester, they're at a huge disadvantage because the lung development that's supposed to be happening in utero is now trying to happen after they've been born, and they're not in a conducive environment for that same lung development to occur. Early oxygen exposure also increases these babies' risk for bronchopulmonary dysplasia because it forms free radicals which cause direct damage to the tissue in the lungs. These babies are born with underdeveloped lungs and also underdeveloped pulmonary vasculature, putting them at risk for high pulmonary vascular resistance and ultimately pulmonary hypertension that often goes along with their BPD. And finally, trauma from mechanical ventilation used to be a much more significant factor before we knew how bad it was to ventilate these babies with high pressure and high volumes. Now we know how traumatic that is to the lungs, and the lungs really struggle to heal from that trauma. So we use a lot less invasive modes of ventilation now that we know how severe it is. The most widely adopted definition of BPD is the Job and Bancalari definition. And in order to meet the criteria for BPD, you have to first be on oxygen for at least the first 28 days of your life. If you weren't on oxygen for the first 28 days of life, then you wouldn't fit the criteria to be diagnosed with BPD according to this definition, which is the most widely accepted definition. Now, the basis for the severity of BPD that the baby has is really based on where they're at once they're at 36 weeks corrected or postmenstrual age. And just as a reminder, your corrected or postmenstrual age is equal to the gestational age plus the postnatal age. So for example, a baby that's born at 30 weeks gestation, who's now 4 weeks old, would be corrected to 34 weeks. So it's the combination of the two. So we look at the babies once they're 36 weeks corrected or postmenstrual age, and if they're no longer on any type of oxygen support, they're just on room air, then they would be diagnosed with mild BPD. Again, they had to have required oxygen for their first 4 weeks of life. These kids usually have very minimal complications, go home without oxygen, and rarely have significant effects from their mild BPD. Moderate BPD is when these kids are requiring some amount of oxygen, but less than 30% oxygen at 36 weeks corrected. So the majority of these kids are your kids who are on a low flow nasal cannula. They often can go home on that, and they have fairly minimal complications from having moderate BPD, but they do still require pulmonary follow-up. Severe BPD is really those kids who stay in the NICU for months and months and months, and those are babies who are on at least 30% oxygen when they're corrected to 36 weeks, or they're on any type of positive pressure ventilation. So if you're on non-invasive CPAP, if you have a tracheostomy, or you're still mechanically ventilated, then you automatically fit the criteria for severe BPD. And that's the majority of these older, bigger kids that we have in the NICU. Just as a disclaimer, these definitions only apply to preemies born at less than 32 weeks gestation. BPD is fairly uncommon in babies born greater than 32 weeks gestation, but they do have slightly different definitions in that population. But since it's so rare, I didn't get into that here. The first pharmacist assessment question, and again, technicians, please answer this as well. You can hold up your answer and also follow along on your sheet. A requirement of oxygen support for at least the first 28 days of life and positive pressure ventilation beyond 36 weeks corrected age meets the criteria for what type of BPD? Yep, I see a lot of C's. So it is severe BPD no matter what their oxygen is at 36 weeks corrected. They are on positive pressure ventilation, so they have severe BPD. And our technician assessment question, a requirement of 25 to 28% oxygen for at least the first 28 days of life and beyond 36 weeks corrected age meets the criteria for what form of BPD? Again, anybody can answer, not just technicians. Good, I see a bunch of B's out there. Perfect, so that would be moderate BPD. They're still on oxygen, but it's less than 30%. The first class of drugs that I'm going to talk about are systemic corticosteroids, and this is by far the most controversial drug therapy that we use in the NICU. Babies who are born with immature lungs are at have a lot of different risk factors for inflammation in their lungs. One significant risk factor is maternal chorioamnionitis, so being exposed to infection and inflammation while they're still in utero, and also sepsis, which these babies are at a huge risk for because they have a lot of invasive lines and tubes and procedures being done during a lengthy NICU stay. Oxygen exposure, again, is on our negative list in terms of causing negative outcomes. Even though it's helping keep these babies alive, we know that the effects of high oxygen exposure early on causes significant free radical exposure and damages lung tissue. And finally, just being on the ventilator alone causes a lot of inflammation in the airway and increases their risk of having BPD. So it makes perfect sense that because they're in this pro-inflammatory state, that corticosteroids would be a perfect drug to use to try and treat that. The problem is that corticosteroids are extremely non-specific. I think of them as a bomb of a drug, and that explains why they're used in so many different disease states. They're not specific at all for the lungs, so they're going to have effect everywhere in the body. Corticosteroids inhibit prostaglandins, interleukins, leukotrienes, cyclooxygenase, again, having impact in multiple different areas in the inflammatory cascade. So they're very effective, but the problem is that they cause a lot of side effects. In animal studies, it's been shown that they decrease alveolarization in the lungs of immature fetuses, and that's a major concern for these neonates because we are really counting on their lungs to develop and for alveolarization to occur. And so systemic corticosteroids could potentially be inhibiting that. These are the different dosing regimens that we use here in our NICU. We primarily are using hydrocortisone and dexamethasone, and more recently we've started using prednisolone. I put the starting doses there, and these are all doses that come from randomized clinical trials where we're getting this dosing from. But the important thing to be aware of is that all of these courses of steroids need to be tapered. And we don't taper steroids in this population because we're worried about adrenal suppression, because their courses are relatively short. They're really not at risk for that. We're tapering these steroids because we worry about a respiratory rebound. So if we stop steroids abruptly in these babies, they usually have a significant increase in their respiratory and ventilator requirements from abrupt withdrawal of the steroids. And sometimes, even though we do wean steroids, they will still have a response after we stop the steroids and have an increase in their respiratory settings, telling us maybe we need to wean even more slowly. Adverse effects of corticosteroids are really significant. These are not your less than 1% chance that you might see in Lexicomp. These are side effects that we commonly see in our population. Hypertension and hyperglycemia are usually relatively short-lived and associated with the dose of steroid they're on. So once we start weaning, we usually see those side effects resolve. Intestinal perforation is more so in your very, very premature newborn neonates, not as significant with our older babies. Bone demineralization we really worry about because we are always trying to play catch up with bone development from the get-go because these babies are at risk of osteopenia of prematurity. Poor growth, as well as poor brain growth, which we have found is associated with neurodevelopmental delays and even cerebral palsy after steroid exposure. And finally, irritability. A lot of these kids just get very irritable and cranky when they're on high doses of steroids. It's important to understand the history of steroids in the NICU to understand their place in therapy today. So in 2002, the American Academy of Pediatrics came out with a policy statement that really cautioned us against the use of steroids in the NICU. They recognized that dexamethasone is very powerful and effective in extubating neonates. However, there was a recent systematic review that had come out in 2001 linking dexamethasone exposure with increased risk of cerebral palsy. And because of that systematic review, the AAP said that we should not be using dexamethasone anymore in neonates except for exceptional clinical circumstances or randomized clinical trials. So in 2002, units essentially stopped using dexamethasone and steroids altogether for extubation because of this warning. Then we saw our rates of BPD go up because we weren't able to extubate patients and get them off the ventilator like we were with dexamethasone. So in the next 8 years, a lot of randomized clinical trials were done. And then in 2010, the American Academy of Pediatrics came out with a revised statement based on the newer trials. They said high-dose dexamethasone is definitely not recommended. The risk of cerebral palsy does not outweigh the potential benefits. They made a statement that there was insufficient data to recommend for or against lower dose dexamethasone. In practice, we do use low dose dexamethasone because it is very effective. It hasn't been associated with the risk of cerebral palsy, but there is concern that it may still increase your risk. We just haven't seen that in the few studies that have been done. Early hydrocortisone may be beneficial, but again, they made a relatively weak statement about that. And they said that there was insufficient data regarding high-dose hydrocortisone. And although hydrocortisone hasn't been associated with cerebral palsy, it's largely not as effective as dexamethasone. They make no mention of prednisolone in this AAP policy statement from 2010. So where does that leave us today? Well, we know dexamethasone is the most potent corticosteroid that we use, and we know that that one is linked to the risk of cerebral palsy. Hydrocortisone hasn't been linked to the risk of cerebral palsy, but it's also largely not as effective in practice. It hasn't been studied head-to-head with dexamethasone, but patients are less likely to be extubated when they're on hydrocortisone compared to dexamethasone. So that leaves us thinking about prednisolone, which is somewhere in the middle in terms of potency. And I put the equivalent doses at the bottom here. So dexamethasone 0.15 milligrams per kilo is our typical starting dose for extubation in accordance with the DART protocol. And that's equal to about 4 milligrams per kilo per day of hydrocortisone, which is equal to about 1 milligram per kilo per day of prednisolone. Unfortunately, there's only one study of prednisolone in our patient population. It was a short-term study, and it showed that there was some minimal short-term benefits to a course of prednisolone of 14 days, but the patients who benefited most were the ones who had less severe BPD. So it's unclear if it helps us at all in our kids with severe BPD. So given that there's no long-term data, we really don't know what the risk of cerebral palsy is because prednisolone has not been studied in this population. It's really important that we weigh the risk benefits for every individual patient before we consider starting the drug. So what we're doing in the NICU here, and this is based on the one study of prednisolone and slightly adapted to make it a little bit of a shorter course, is starting prednisolone 1 milligram per kilo every 12 hours. Now I do want to point out that if you remember from the slide about the potency, that is twice the equivalent starting dose that we're using of dexamethasone. So providers are often asking, can we go up even higher on the prednisolone? If you look at it in Lexicomp, it has a really wide range of doses that we use for prednisolone for various indications. And my recommendation would be that we need to be really careful with its use because it's possible that the same thing that happened with dexamethasone, where we found later that the high doses were associated with cerebral palsy, but the low doses weren't, I could foresee the same thing happening with prednisolone because it just hasn't been studied enough yet. So at this point, I recommend being relatively cautious with dosing, and if patients respond after 5 days of this dose, then we can taper it over 5 days, again to prevent that rebound respiratory effect. If they don't respond after a 5-day course, there's really no reason to taper it, and we can just stop it at that point. There's also a very small subset of these complex chronic NICU patients who end up becoming very, very highly responsive and dependent on steroids. We'll see that they just do not tolerate weaning or coming off of their steroids. And this can be seen by increases in their ventilator or respiratory requirements, but also just increased irritability. It could be a sign that they're air hungry, they're having to work harder to breathe, they're less comfortable with the way that they're breathing. And also if they're not tolerating physical therapy, occupational therapy, or even just playing with their parents, that could be a sign that they're not tolerating coming off their steroids. For our little babies, playing and doing physical therapy is their form of an exercise challenge. That's what they need to be doing at this age. And if they're not able to tolerate that, then that's a sign that something's going wrong. So if that does happen, they're not tolerating coming off their steroids, we would go back to the previous tolerated dose and then wean even more slowly from there. Usually we'll wean about once a week and as low as 10 to 20% per wean, and that's completely dependent on the patient. The place in therapy for steroids is definitely for extubation. That's where the majority of the data has been done. However, we're also using steroids sometimes when our chronic patients are having increased respiratory requirements above their baseline. However, steroids should not be used repeatedly in patients who fail to respond to their initial course. If they don't respond to steroids, we really are just increasing that risk of adverse effects without any benefit by continuing to provide them with steroids. And steroids should also not be used to try to establish a new baseline in a chronic patient. If a patient has a chronic oxygen requirement of 40 to 50%, we would love to try to get that down, and steroids might do that for a short time, but they're not going to bring that baseline down to a new level. The best thing we can do for that child is let them try to grow. The next pharmacist assessment question is, the DART dosing protocol starts dexamethasone at 0.15 milligrams per kilo per day. What is the equivalent dose of prednisolone? Correct. It's B, 1 milligram per kilo per day. And that's just a reminder, we are usually starting at 2 milligrams per kilo per day. So keep in mind that that's even higher than our equivalent dose of dexamethasone that we're normally using. Technician assessment question, which of the following indications has the most evidence to support the use of systemic steroids in BPD? Good. It's D, to facilitate extubation. And one more technician assessment question. Which of the following adverse effects prompted the AAP to issue a policy statement in 2002 cautioning against the use of dexamethasone for BPD? Yes, it was D, cerebral palsy. The others are side effects as well, but it was that risk of cerebral palsy that made the AAP make that strong statement. Awesome. So inhaled corticosteroids are maybe the second most controversial therapy that we use in the NICU compared to systemic corticosteroids. It makes perfect sense that by delivering a steroid directly to the site of action where we want it to work, it should have benefit without having as many side effects as systemic corticosteroids. Unfortunately, this remains to be proven, and the studies just don't really support their use very strongly. I think the major factor that explains why they don't work very well in our patients is that BPD patients have such inflamed fibrotic lungs that the drug is not able to get into the lower airways, which are most inflamed, because there's just all closed off. And so that's probably why we don't see a major effect from these drugs. A Cochrane review in 2012 compared patients who received inhaled steroids to patients who didn't. They included 7 clinical trials and found that there was no difference in BPD between the two groups. However, there was a lot of heterogeneity in terms of what steroid was used, what dose was used, and when it was started and for how long. So it's hard to draw a really strong conclusion from the combination of so many different clinical trials. Then in 2016, there was another meta-analysis that included a few more clinical trials that were done in the late 2000s, and they showed that there was a decreased risk of BPD in patients who received inhaled steroids compared to patients who didn't. The number needed to treat was 14, meaning that we would have to treat 14 babies with inhaled corticosteroids to prevent one baby from having BPD. So clearly, they're not effective in all patients, but there does seem to be a small subset of patients who do respond very well to them. Again, in all these clinical trials, there was a high degree of variability in terms of what steroid was used, the dose used, and how long it was used for. When you look at a meta-analysis that says it has significant effects, it's really important to look at the breakdown of all of the different studies that were included in it. So if you see here, this meta-analysis showed a significant benefit from inhaled steroids, but it was really just this top study highlighted in yellow that individually showed a benefit of inhaled steroids. So that one study really drove the response of this whole meta-analysis. And in that one study, they were starting inhaled corticosteroids within 12 hours of the baby being born. And that's clearly not something that has caught on in practice, likely because that's one positive study in the setting of a lot of other studies that show that they had no benefit. The way that I like to choose which corticosteroid to use, because the data is really all over the place and doesn't show that one is better than the other, is based on the particle size. So Qvar or beclomethasone has the smallest particle size, with fluticasone or Flovent being a little bit bigger and budesonide or Pulmicort being the biggest of the three. The smaller particle size increases the likelihood that it can actually get into the smaller inflamed airways. However, you also have to think about how the drug is available and how you're going to administer it to the baby. So babies who are on the ventilator, either with a tracheostomy or just intubated orally, can easily get an MDI inhaler like Qvar. They will administer it right above the ET tube, and it goes directly through the tube and into their lungs. However, a baby that is on some type of nasal respiratory support, so nasal CPAP or a nasal cannula, it's much harder to give them an MDI. You have to administer it with a spacer and a face mask, and that usually requires that you remove their nasal prongs in order to give them the face mask to give the drug, and most of these babies can't tolerate being off of their nasal respiratory support for the 30 to 45 seconds that it takes to administer the drug. And in that case, you might have to use a nebulized inhaled corticosteroid, which can be given with the humidified air right through the circuit of the nasal support. So that's why you may see us switch between types of inhaled corticosteroid depending on what type of respiratory support the baby's on. The dosing that we're using for inhaled corticosteroids here is a lot higher than what you would see in Lexicomp. And the doses have been studied really a very wide range in all the different clinical trials. Up to 1,000 micrograms per kilo of Qvar has actually been studied. And we found that less than 5% of the dose actually gets into the lungs in babies who are intubated or have a tracheostomy. So very, very little drug is even getting beyond the tube and into their lungs at all. So we're using relatively high doses to try and overcome that. That does mean that these patients could potentially experience systemic side effects from steroids. So if patients are having trouble growing or they're having uncontrolled glucose or hypertension that seem to come out of nowhere, I would consider looking and seeing if it was associated with starting the high-dose corticosteroid, because it is possible that they're getting some systemic absorption from it. Given that, again, there is a lack of high-quality evidence to support inhaled corticosteroids, their use should be very individualized and patient-specific. There clearly is a subset of patients who do respond to inhaled corticosteroids, so I think it's our job to make sure that when we try inhaled corticosteroids in one of these patients, we're really assessing the response to it and seeing if they have any benefit. Now, the best way to assess the response of these inhaled medications is to do PFTs or pulmonary function tests. We currently do not have the equipment to do that for infants here, but we are working on getting that equipment. And that would be the best way to assess whether their lung function actually improved after starting the inhaled medication. But for now, we're just looking at their oxygen requirements, their tolerability to play and therapy, and also their overall comfort with breathing. There is no data on the use of inhaled corticosteroids with systemic corticosteroids, so generally we will hold the inhaled steroid if we're starting a high-dose systemic corticosteroid and then restart it once we're closer to weaning off of the systemic steroid. And finally, I would consider using an inhaled corticosteroid in patients who have been responsive to steroids in the past and need long-term management. It may potentially help us decrease the use of systemic corticosteroids if their inhaled corticosteroid is enough to just keep them comfortable and not need systemic steroids. The next sort of group of drugs that I'm going to talk about are those for pulmonary hypertension. Pulmonary hypertension can ultimately end up in a really vicious cycle for these babies. They might get hypoxic for any reason at all, whether they were briefly disconnected from their vent to change their outfit, or something happened and they became upset or irritable. Maybe they had a blood draw or a heel prick for some reason. So any event that causes some amount of hypoxia leads to pulmonary vasoconstriction. The pulmonary vasoconstriction then decreases the blood flow you have going to your lungs, and that puts them in a pulmonary hypertensive crisis. This pulmonary hypertensive crisis leads to further hypoxia because you're not able to oxygenate your blood, and that causes further vasoconstriction, and it's incredibly difficult to get them out of this cycle. This is the type of baby you'll see that's turning blue and has very low saturations, and the RT will be bagging them, forcing breaths into them, and it does not help at all whatsoever, because no matter how much air you put into them, if their lungs are not oxygenating their blood, then their saturations stay low. The best thing we can do for these kids is to help calm them and relax them, which will help vasodilate their pulmonary vasculature. Because of this vicious cycle, these kids are at a very, very high chance of mortality. They're at high risk of sudden death if they do get into one of these crises. And these babies with BPD, because their lungs are so underdeveloped and their pulmonary vasculature is too, they have very vasoreactive pulmonary vasculature. So they are highly susceptible to anything sort of setting them off, causing irritability, making their vasculature reactive, and causing hypertension. They end up with high pulmonary artery pressures, which leads to vascular remodeling, and it can also lead to right-sided heart failure because their heart is constantly trying so hard to pump against these really high pressures in their pulmonary arteries. The best treatment that we can do for pulmonary hypertension is to treat their underlying lung disease and to help facilitate growth of the baby. And this is directly from the American Heart Association guidelines. They actually have their own section on pulmonary hypertension in infants with BPD because it's really its own pathophysiology that is different from other forms of pulmonary hypertension. Inhaled nitric oxide is a pulmonary vasodilator. I'm not going to talk about it as much because it's really only used for short-term treatment. It's not a long-term option for these patients, but it can be administered very quickly, inhaled continuously, and get directly into the pulmonary vasculature to help dilate those arteries. Sildenafil and bosentan are the most common drugs that we're using for long-term management of these kids with pulmonary hypertension. I included the dosing of sildenafil and bosentan here. It's directly out of the American Heart Association guidelines, and there are maximum doses that we will use for both drugs. Now, sildenafil is a phosphodiesterase inhibitor, and bosentan is an endothelin receptor antagonist. They both have different mechanisms of action. Both are causing vasodilation of the pulmonary arteries. So it is possible that we could use these two medications together if we max out on one of them and our patient still is not fully controlled. You could add the other one because the mechanisms are different. Sildenafil often causes hypotension, and that's why we'll start at a low dose and slowly increase it to make sure the patient tolerates it well. And it does have a black box warning that higher doses above 1 milligram per kilo are associated with increased mortality. So that's why we typically stop at 1 milligram per kilo 3 times a day. And bosentan can cause peripheral and pulmonary edema, which is often a significant concern in these babies. It's helpful to look and see if they've been requiring diuretics, Lasix, or Diaril at some point recently. They are at even greater risk for having pulmonary edema and peripheral edema from starting bosentan. And they may require increased diuretics, which also have their own set of side effects. Bosentan also is in a limited distribution program, so it can only be ordered from certain pharmacies and by registered providers because it has significant safety risks. It is a teratogen, which obviously is not a concern in our babies who are starting therapy, but it is a concern for moms who are going to be administering the drug at home, that it can cause birth defects if they are exposed to the drug. And it's also hepatotoxic. You have to check LFTs before starting therapy and every single month for the duration of therapy. The hepatotoxicity can happen at any time. It doesn't just happen at the beginning. It's not necessarily dose related, and it can be very severe. So it requires frequent monitoring. And for that reason, it's only available through certain pharmacies. Also, it's really difficult for us to administer because it's only available in adult dosing tablets. There's no suspension that's currently available, so parents have to be trained how to mix it and draw it up at home. So in terms of treating pulmonary hypertension, we'll usually start with inhaled nitric oxide because, like I said, it's going to give you an immediate effect by opening up the pulmonary vasculature. Then we would transition to sildenafil. Because it has less severe side effects than bosentan, it's generally the recommended first-line option. There's also more data on sildenafil in this patient population compared to bosentan. We usually start the dose low, again because of the hypotension you can see, and titrate it every couple of days. Bosentan really should be considered a last resort in patients who are refractory to sildenafil and refractory to optimized lung therapy because of the significant safety data and lack of efficacy. Also, I just want to mention that there are some inhaled as well as continuous infusion prostacyclin derivatives such as epoprostenol or treprostinil. The guidelines do not recommend their use in this patient population because they haven't been studied. It has been brought up a few times in our patients with really severe refractory pulmonary hypertension, and although there's no data to support it, it may be sort of a last line option for these patients. In order to monitor whether they're actually responding to this therapy or not, we're going to watch their oxygen requirements because you would expect if you're starting a drug that vasodilates the pulmonary vasculature, should make it easier for them to oxygenate their blood, and therefore the oxygen requirements that we're putting in through their ventilator should go down. We also will monitor serial echocardiograms, which are a fairly non-invasive way to look at their pulmonary hypertension. But it's important to remember that those are just one small point in time that the echo is being done. So just because they didn't show pulmonary hypertension on their echo doesn't rule it out completely. We'll also measure their blood levels of BNP, and that's a sign of right-sided heart failure. So patients who have a BNP that's going up and up indicates that the right side of their heart is working harder and harder and being stretched more, probably fighting against high pulmonary vascular pressures. The gold standard, and the guidelines say it everywhere, is doing a cardiac catheterization because that's the best way to really see what's going on in the pulmonary vasculature and to test whether they're responsive to oxygen or to nitric oxide at all. Unfortunately, these patients are often too unstable to go to the cath lab and undergo anesthesia and sedation for that procedure. So we more often do echocardiograms since they're much less invasive. But if we can, a catheterization is really by far the best way to assess their response to therapy. So again, patients are going to be started on medications for pulmonary hypertension typically based off of their echo reports. It should always be added on after their chronic lung disease has been maximally managed because the guidelines say, and we see in practice, that if you don't treat the lung disease, treating the pulmonary hypertension is essentially just putting a Band-Aid on a bigger problem. We have another technician assessment question. Which of the following is a side effect of sildenafil? Yes, I see a bunch of A's. Hypotension. The others are side effects of bosentan. The final category of drugs that I'm going to be talking about today are sedatives and analgesics. And I'm going to be talking about them in the sense of iatrogenic drug withdrawal. So we essentially have two different classes of medication that we can choose from for our neonates who require sedation. We have opioids, which include morphine, fentanyl, methadone. They're primarily used to treat pain. They happen to cause sedation as a side effect. Benzodiazepines are primarily to treat agitation or anxiety, and they cause sedation by their primary mechanism of action. So if I'm asked for a recommendation on sedating a patient, my first question is always, are they in pain or do they have a reason to be in pain? Obviously, babies can't really tell us that they're in pain or not, but I really look at the big picture. Do they have tubes in? Do they have lines in? Have they had a recent surgery? Do they have some reason to be in pain? If they do, you definitely have to treat the underlying pain maximally first, because if you start an anxiolytic like a benzodiazepine, you're essentially just masking the problem. If they don't have a reason for pain, they are just agitated, irritable, they are just a cranky little 4-month-old that can't be settled down, then you would consider just using a benzodiazepine because you really don't need the opioid if they don't have a reason for pain. In our patient population, we would prefer to just use one drug if possible. Reasons why these babies need to be sedated. The major reason is if they have any type of invasive mechanisms that are causing them agitation that are needed for survival. So the most common one that I see is the high frequency oscillator ventilator. It's providing a very, very fast respiratory rate to these babies. You can see their chest going up and down very quickly. And it can be very uncomfortable because it's a very unnatural form of ventilation. So if they're trying to fight that and they're agitated from being on that ventilator, they may need sedation. Clearly, our babies who are on ECMO pretty much always need sedation as well because, again, it's very invasive. We're doing it to save their life, but they're not so happy about it. If they're agitated to the point that it's impeding care that we have to do for them, for example, if every time the nurse goes in to change their diaper and touches them, they get agitated, their saturations drop, they're needing increased oxygen, that would also be a reason to give them some sedation medication. And finally, we try to only use medication when they're unresponsive to non-pharmacologic methods. You'll see a lot of our little tiny preemies are on no sedation or analgesics at all. They're intubated and they're perfectly happy if they can be swaddled up really nice and tightly and in a nice dark isolette with a blanket covering it, and they really don't have a problem with it at all. But in our older babies who are approaching 4, 5, 6 months old, they are usually not so responsive to being swaddled up. They just want to get out of there and pull the tubes out of their mouth because they're more aware neurologically of what's going on. So our older kids are a lot harder to deal with and more likely to need some medication. There are significant risks, just like all of these drugs, in using sedatives and analgesics in our patient. The biggest risk is neuronal apoptosis. In these little tiny babies who have premature brains already, they're already at risk of having poor neurodevelopmental outcomes because of their prematurity, and sedatives and analgesics have been associated with worse neurodevelopmental outcomes. There was a recent FDA warning for patients who are less than 3 years old against the use of anesthetics and sedatives repeatedly, and that's because of the risk of neuronal apoptosis. They may also be less able to participate in physical therapy, occupational therapy, and in just normal infant play if they're sedated. Although that's kind of a double-edged sword because sometimes these patients need to be just slightly sedated enough so that they can tolerate physical and occupational therapy coming in. To me, the biggest concern with starting sedatives in these babies is that we could be masking an underlying untreated medical problem. So if a baby is suddenly agitated, irritated, unhappy, and they're asking for some medication to help calm them, I'm always asking the question, have we thought about other disease processes? Could they be getting sick? Are they starting to show signs of sepsis? Could they be having pulmonary hypertension that we haven't diagnosed? Maybe we're not managing their ventilator well and they just are not feeling natural and happy on that. So I would want to rule all of those things out before we start medication and mask an underlying problem. There are multiple different ways that we can give sedation to our patients. One is by giving PRN boluses, either IV or PO, really doesn't matter as long as it's dosed appropriately. And this allows us to try non-pharmacologic methods by calming them, by holding them, whatever the baby likes. We can try that first before we resort to giving medication. However, in our babies who are very agitated, for example, babies who are on the oscillator or intubated, constantly trying to pull out their tube, giving a PRN bolus is reacting to a problem that's already happened. If we give scheduled boluses, that allows us to stay on top of their sedation and hopefully prevent bad things happening, like pulling out their tubes or potentially harming themselves in some other way. And we can also give drips. That requires IV access, which most of our bigger babies in the NICU do not have and can be very, very difficult to obtain. So really, it just eliminates the need to have to give medicine continuously, but it's not necessarily more efficacious than just giving scheduled boluses. I included the starting doses here really because I want to point out that your starting dose for IV morphine and PO morphine are completely different. And the same is true for midazolam. Your PO dose is much higher than your IV dose, and this is something that in the NICU, we are not necessarily always very good about being aware of. We kind of forget that the PO dose has to be a lot higher than IV because of limited bioavailability. So if you're switching from IV to PO and you want to maintain the same level of sedation, you need to increase the dose quite significantly. And a lot of times providers are kind of hesitant to do that because it can be scary due to concern that you might overdose them. but we have to remember that you're not absorbing the entire dose when you're giving it PO. We also have to think about these big, complex, chronic NICU babies as pediatric patients, not as neonates. So they overall require higher doses of sedatives and analgesics. They have better hepatic function, better renal function, and overall just faster metabolism than little premature neonates do. They're a completely different patient population, and we really need to make sure we're dosing them adequately. I know I've gotten a few questionable looks when I've recommended these doses of sedatives, which I don't think we would think twice about in a patient admitted to a pediatric unit, because they're in a neonatal unit, we're thinking them as neonates, forgetting that they really are a pediatric patient. So we should really be using Lexicomp for dosing these medications rather than Neofax, since they're not neonates anymore. Intranasal Versed we've been using more and more, especially in these bigger kids. It really has worked out very well. The benefit compared to oral is that it has a much faster onset of action, but it does not last as long as oral. So you have to remember, it's going to calm your baby quickly, but for a fairly short amount of time. It's administered using an atomizer, which converts the IV drug into tiny little particles that go right into the nose, and it's absorbed through the nasal mucosa. And we give about half the dose in each nostril. It doesn't have to be completely precise. It's best for patients who don't have IV access, which, like I said, most of these bigger kids don't, and it's really hard to get IV access in them. A lot of times we actually have to use intranasal Versed in order to get an IV in them, because like I said, a little bit of agitation can set these kids over the edge and put them into a crisis. Patients who are on sedation for long periods of time, although we do our best to limit its use, some of these kids will just require being on sedation. If they're on drugs for more than 7 to 10 days, that's typically when we consider them being at risk for withdrawal, although it's really patient specific, and you certainly can withdraw from medication even if you're on it for less than 7 days. We also have to remember that if the medication was ordered PRN, that doesn't mean that they're not at risk for withdrawal. If they were getting it frequently and around the clock, they still are at risk for withdrawal. It's really important that we choose a drug of the same class to treat their withdrawal. So if the patient was on a Versed drip, we would want to treat withdrawal with oral lorazepam. And if the patient was on morphine or fentanyl, we would want to treat with another opioid like morphine or methadone. And a lot of times I get questions from some of our nurses about why aren't we using methadone in this patient? And the answer is usually because if they were withdrawing from midazolam, methadone wouldn't help them because it's not hitting that same receptor. So if anything, it could just be masking the withdrawal without actually treating the withdrawal at the receptor level. Withdrawal is best categorized in terms of opioid withdrawal. Unfortunately, we don't know a whole lot about benzodiazepine withdrawal, but we sort of extrapolate the opioid symptoms and assume that it's fairly similar for benzodiazepines. They may have autonomic symptoms like increased respiratory rate, increased heart rate, motor symptoms, they're jittery, behavioral problems, so they are just irritable and cranky and not happy, or GI symptoms like diarrhea. I shouldn't say it's new, but it's fairly new to our institution, called the WAT1 scoring system. It's the same scoring system that Megan recently talked about in the Oreo that they started in the PICU. We're not currently using it in the NICU, but it should be a consideration for these bigger kids. It's been validated for patients who are 2 weeks to 18 years old, and their total score is between 0 and 12, and it's really helpful for trending their scores to see if they're slowly trending up. It may be an early sign of withdrawal. And it's really helpful because it will be able to detect withdrawal before the patient is essentially in full-blown withdrawal. Right now in the NICU, we have, of course, NAS scores, but those are only validated in neonates who are just born, who are withdrawing from maternal substance abuse. So I recommend against using that scoring system for our bigger NICU babies. I don't think it's a good use of the nurse's time because they have to score them every 3 hours, and it's really not helpful for making clinical decisions. So if anything, we would be better off using this WAT1 scoring tool. It's actually a lot shorter than the neonatal abstinence scoring tool, and it's only done twice a day, every 12 hours. So I just have an example because I think sedation is easier to explain in the context of a patient, and I will preface this by saying that every patient is different, and there's definitely no one-size-fits-all to iatrogenic drug withdrawal. We had a 3-month-old, 24-week gestational age infant who weighed 2.5 kilos. She was on a Versed drip because she got started on the high frequency oscillator, and at 3 months old, she was not too happy about it and very agitated. She was on the midazolam drip for 8 days, titrated up to a maximum dose of 0.15 milligrams per kilo per hour, and she also had an order for PRN morphine. And they asked for recommendations regarding getting her ultimately off of sedation. So my first question is always, is she in pain or does she have a reason for pain? Well, she has an ET tube in, so she may have some pain or discomfort for that, but nothing that would be severe enough to be requiring IV morphine. And sure enough, she had not received the IV morphine for over a week. So she definitely wasn't at risk for withdrawing from that. My next question was, how is the patient doing clinically, and what are our overall goals of care? Are we wanting to extubate her and get her awake and alert and playing in the next couple of days? Or is she still very tenuous and sick? And in this case, this patient was still very tenuous and sick. So we wanted to start a very slow sedation weaning process that wouldn't set off her underlying lung disease. Which of the following drugs would be appropriate for weaning a patient off of an IV midazolam drip? Yes, PO, lorazepam would be appropriate. The others are opioids, so like I said, they wouldn't be targeting the same receptor, and if anything, they could just be masking withdrawal symptoms rather than actually treating it. So what we did for this patient was wean the midazolam drip by 50% today. You're not going to have immediate effect by decreasing the dose of a drip since you have significant body stores. So I would see how she does coming down on the dose by 50% today. Then the next day we start PO lorazepam. We're typically starting just at 0.1 milligrams per kilo PO. It is also possible to convert the midazolam dose over to PO lorazepam. But this tends to work really well in our patients, and we can always go up or down on the dose as we need to. We give it every 3 hours schedule because all of these neonates are being fed every 3 hours, so they get it automatically with their feeds. We don't want to automatically convert it to PRN and respond to signs of withdrawal because we're trying to prevent her from having withdrawal. I then recommend weaning by 10 to 20% of the dose every couple of days, and the number of days is generally equivalent to the number of weeks we've been on sedation. So this patient's been on sedation for 8 days, then you could wean as quickly as every single day. This patient was very tenuous, like I said, and our overall goal of care was for a very slow wean of her sedation, and so we wouldn't wean that quickly. She was very unstable from a respiratory perspective, so we really had concerns that if we did wean too quickly, it might put her over the edge. And finally, you always want to calculate out what your dose is to make sure it's going to be measurable. And generally in these babies, I will just go down to the smallest measurable dose and then start weaning the interval. The final pharmacist assessment question, the WAT1 scoring tool is validated to assess withdrawal from which drug or drugs? I see some D's. Yes, both opioids and benzodiazepines. The place in therapy for these sedatives and analgesics, again, is after non-pharmacologic methods have failed, after we've ruled out any underlying medical problems, and when the benefits outweigh the risks for that one specific patient. It's not a one-size-fits-all. Not every patient who's intubated needs to have sedation and analgesia. So in summary, I've talked about a lot of different drugs here. I think the take-home message is that, unfortunately, none of these drugs are a great fix for bronchopulmonary dysplasia. They're one very, very small piece of the total management of these chronic babies with BPD. So what is it like to grow up in the NICU at Winnie Palmer? Well, we have a new complex care unit for these babies that we are admitting to that unit. It's still within the NICU, but it's its own 4-bed unit with consistent nurses and other providers every day. And we have multidisciplinary rounds every day with the physician, nurse, respiratory therapist, physical therapist, occupational therapist, speech, dietary, and pharmacy. So as you can see, pharmacy is really just one very small piece of the puzzle. All of these developmental activities are really the best things that we can be doing for these babies to try to normalize the fact that they are literally growing up in a neonatal ICU. We also have other consult teams that join us for rounds. So the pulmonology team comes once a week to rounds, and the cardiology team comes once a week, and palliative care is also going to start coming once a week and joining us. The goal is really to provide a very patient-centered and family-centered approach to their care, involving the parents every step of the way, rather than just looping them in when it's time to get ready to send home their very complex baby. And I just want to leave you all with a happy note. We recently had a baby who was born at 29 weeks and 3 days. He was only 560 grams when he was born because he was severely growth restricted. And he was born to a 35-year-old G1P0A0 mom. She did get pregnant by in vitro fertilization after several failed pregnancies previously. And when he was 9.5 months old, just about a month ago now, he was discharged home. He weighed 6.2 kilos, literally 10 times the size that he weighed when he was born and admitted to the NICU. He was discharged home on a whole slew of medications, pretty much the picture-perfect example of this entire presentation. He had very, very severe lung disease related to his very small birth weight, and he was discharged home on a tracheostomy and ventilator. And he's doing awesome at home now, and I can guarantee that every single person in this room had some part in this baby's 9.5 month hospitalization, or in mom's 1 month hospitalization before he was even born. So whether you were managing mom when she was on antepartum for a month, whether you verified some of his orders, checked his TPNs, checked some of his IVs, helped make his Bosentan, helped order more Bosentan to make sure we could send him home, helped create policies so that we could send him home on Bosentan, or other clinicians who helped me bounce ideas off of his terribly complicated sedation weaning plan. I guarantee that every single person played a role in getting this baby to a point where he could go home, and that's really something to celebrate. And this was a picture of the onesie that he wore on his last day in the NICU. I'd be happy to answer any questions you guys have. Any questions? All right, thank you guys. Let me give you the CE code.